My name is Cody Bell, and I'm going to do a presentation on lung pathophysiology with ventilator therapy. We're going to first go over your basic airway knowledge, upper and lower airways, how oxygen and carbon dioxide are transferred in the respiratory system, different lung diseases, and how you would ventilate different patients with these lung diseases. So the goals for this presentation is to discuss the anatomy of the pulmonary system from the upper airway all the way down to the cellular level, the physiology of the lungs, disease pathology, and ventilator therapy. So the upper airway is there to filter and humidify air as it's being brought into the airway. It consists of the nose, mouth, throat, and pharynx. This is part of whenever you're assessing a patient to intubate them, you're going to look at the upper airway to, like if you're doing a Lemon scale, look for external obstructions, evaluate the 3-3-2, the Mallampati. That you'll get if the patient's able to open up their mouth, stick their tongue out, you'll be able to assess that. Any internal obstructions in their mouth, big tongue, broken teeth, any trauma, bleeding or fluids, vomit, and then also their neck. You're going to assess their neck mobility if they're in a C-collar or if they had like extreme kyphosis or anything like that. So, along with what the upper airway does, that's as a clinician, you should also be assessing that for your patients. The lower airway is the larynx, trachea, bronchi, respiratory bronchioles, and alveoli. So if you look here, going back to the intubation thing, or advanced airway management, this is your cricothyroid membrane. So this is where you would insert a needle or surgical cric. And if you look here, you hear of people being right main stem when they're intubated. Of course, this is elongated, so it's really easy to stick an ET tube down in here. The right bronchi is more straight than the left, so that's why that ET tube's more easily placed into the patient's patient's right main stem. These are a microscopic view of the tissue in the lower airways. You got submucosal glands, columnar epithelia, cilia, and lumen cells. These all assist in the compliancy and make up the structure of the lower airways. The bronchi, as the trachea bifurcates at the carina into the right main bronchi and left main bronchi, they further branch off into secondary and tertiary bronchi and continue to get smaller until they reach the terminal bronchi. And these are the tiny little branches in your lungs that the alveoli are attached to at the end. And all those are, all these structures are made of cartilage. So they kind of have they're more stiffer, kind of like, feel like your nose, all that. The respiratory bronchioles, at the terminal bronchi end, smooth muscle begins with the respiratory bronchioles, which lead to alveolar ducts. So, like I said, here's your main stems, your bronchi, and at the end of here, where your alveoli, and that's where actually gas exchange happens. Alveolar ducts lead to alveolar sacs and end at the individual alveoli where gas exchange takes place. So here's your bronchi, there's your alveoli, look like a thing of grapes at the end. So your oxygen depleted blood surrounds the alveoli, CO2 leaves, oxygen comes in. When you have patients with like asthma or some kind of obstructive pulmonary disease, you'll get mucus or fluid between here, and it obstructs gas exchange, and that's why you have patients who, with CHF, fluid backs up in the lungs, leaks out of the alveoli in between here, and your gas exchange makes it harder for gas to exchange and thus trap CO2 in the body, resulting in decreased SpO2 readings. The alveolar structure, they're tiny balloon-like structures that together appear like a cluster of grapes. They comprised of epithelial cells, type 1, type 2 cells, and alveolar macrophages. Sorry. The pleural cavity, that's everything that, or that's the cavity that holds all your lower airways. So it contains right and left lungs. The base of it rests at the diaphragm, which obviously is with negative pressure is what causes you to inspire oxygen. Apexes of the first rib. The right lung has 3 lobes. The left lung has 2 lobes due to the heart. Each lobe receives a tributary of the bronchial tree, pulmonary artery, and pulmonary vein. So each bronchial tree, that's the how the blood is coming and going to and from the heart. So again, here's a diagram of how blood is brought to the lungs, back out to the heart. So the it comes from the lower part of your body. So you get renal vein, hepatic vein, all your upper bodies. Here's a vena cava that comes straight into your right atrium. It goes right atrium, right ventricle, lungs, left atrium, left ventricle, body. And again, shows a diagram of how blood goes around the alveoli, gas exchange happens, oxygen comes in, CO2 goes out. When you exhale, you blow out CO2 out of the alveoli, and when you inhale, oxygen comes in, the system starts all over again. So any medics who are in the hospital setting or doing inter-facility transfers need to be familiar with ABGs. That's your normal blood gas readings. So your SaO2, which is your pulse ox, needs to be between 94 and 99%. Your PaO2 needs to be between 80 and 100. That's your oxygen reading in your arteries. PaCO2 is between 35 and 45. You want to maintain a pH between 7.35 and 7.45, and a bicarb between 22 and 26. Different lung diseases, respiratory rates, based on the patient's condition, can change all of those figures, either acidosis or alkalosis, and it can go from respiratory acidosis to metabolic acidosis, and vice versa. So it's all a system and it needs to work together. So dead space. Everybody has dead space. There's dead space. There's mechanical dead space, anatomical dead space, and physiological dead space. Mechanical dead space has to do with your ventilator, mostly. Mechanical dead space is the volume of air in the ventilator circuit that does not allow for gas exchange. So every ventilator is going to have air left in the circuit. So when you have a set tidal volume, that's including the air that makes it to your lungs as well as the air that stays in your ventilator circuit. So some places, not every place, I know in air evac we don't calculate for dead space in the adult because it's so minimal, but if you're going to calculate it, it's 1 to 2 mils per kilo for tidal volume, for the patient tidal volume for the dead space. You do need to consider it in pediatrics and neonates because their tidal volumes are so low that if you do have some dead space, if you have a baby that's only 60 mils for tidal volume and 20% of that is in the dead space, where you're talking a substantial amount of the air that's supposed to be getting to his lungs that's in the dead space. So it's something you really need to think about for babies. For adults, we pretty much use chest rise, PIPs, maintaining pips in the desired ranges, your pulse ox reading, and your capnography. And that's what drives our vent therapy and how we adjust our vent, rather than just figuring on the 1 to 2 mils per kilo for the dead space. Anatomical dead space. The average upper airway anatomical dead space in adults is about 150 mils. And that's every healthy adult, which it increases with different disease processes. COPDers, they're air trappers, so they're going to have more dead space. When we intubate a patient, we take away that anatomical dead space and we reduce it down to about 4 to 10 mils. So you're utilizing more oxygen that you're putting in. Also with smaller airways, it will increase airway resistance. Physiological dead space. Physiological dead space are the areas inside the lungs which do not provide gas exchange. The bronchi, bronchioles, and even some of alveoli are dead space. If alveoli are loose or surfactant, like in your COPDers, and they're not opening to accept oxygen, then they're contributing to the physiologic dead space. This can change with the patient's position, disease processes, hemodynamics, and those all create a VQ mismatch. So blood in the lung, pneumonia, anything that's blocking gas exchange is adding to your physiological dead space. The normal VQ ratio is 0.8, with there being more perfusion than ventilation. So more blood is being circulated through your lungs, basically, then that can actually get gas exchange. So you're always going to have a little bit of a mismatch there. But the only way to really tell accurately what your VQ ratio is a VQ scan, and that calculates a very specific physiologic dead space. Lung capacities. The average adult contains about 6 liters of air. When a patient's quiet breathing or almost has absent breath sounds, your severe case of like status asthmaticus, and where there's not getting any exchange, you're looking at 2.5 to 3 liters per breath. Residual volume is about 1,000 mils that never leaves. So after you expire, your expired reserve volume, so that's after you exhale, you have about 1,000 mils that never leave your airway. So the inspiratory reserve volume is the amount of air that's forcefully inhaled. Functional residual capacity is a sum of the residual and the exhaled reserve volumes. This is stuff that when you really get into ventilator management, you need to keep in mind, just so that you're adequately ventilating and oxygenating your patient. The pressure inside the lungs, your lungs naturally want to collapse. So the chest wall wants to expand. So when the chest wall expands, it pulls on the lungs and keeps them open via your diaphragm. So when your diaphragm drops, your chest expands, pulls your lungs open. It takes about 30 millimeters of mercury of pressure to do this, and which in turn leaves about 1,000 mils of air inside your lungs, creating a positive transpulmonary pressure. This is your body's natural way of preventing pneumos. So your body naturally breathes in a negative pressure via your diaphragm. So when we intubate somebody and put them on a ventilator or BVM, you're switching their whole body up, going from negative pressure to positive pressure. So that's something to think about, and we'll discuss later in the presentation. Intrapleural is always more negative than the alveoli, and which is always near 0 millimeters of mercury. When we add positive pressure ventilation, we alter the gradient and compress the airway. So we're putting more strain on the airway because we're forcing air into the airway rather than drawing it in through a negative pressure. Again, our diaphragm creates a negative pressure on inhalation, pulling down, causing the air to rush into the lungs, whereas when you switch them over to positive pressure ventilation, like I just said, you're doing just the opposite. You're forcing air in that's unnatural to the body into the airway. So it's a lot easier to cause barotrauma, breath stacking, overinflation with positive pressure rather than negative pressure. Physiologic PEEP. So walking around, talking to you right now, everybody naturally has PEEP. It's what helps our lungs stay open, our alveoli stay open. It helps with elasticity. So natural PEEP is around 4 to 5 millimeters of mercury. So it's real important to, no matter why you intubated your patient, even if you had to intubate a patient based on no lung diseases or respiratory issues at all, if it's a trauma patient, always place them on with a PEEP valve, because you don't want to take them from 4 to 5 millimeters of mercury PEEP to none. So every patient should get a PEEP valve on their BVM. Every patient should have a minimum of 5 PEEP when they're on the ventilator, in my opinion. There's always some cases where you don't need it, but every one of my patients gets a PEEP of 5 when they're on the ventilator. Or if they're on a BVM, I got a PEEP valve on, it's turned to 5. Now, with other lung diseases, you're looking at increasing that PEEP 5, 7.5, 10, 15. For the severe COPDers, that it's real important to recruit as much alveoli as you can and keep it open. Keep those alveoli open, because what happens with COPDers, if you're bagging a COPDer at 10 with a PEEP of 10, take that BVM off, you lose all your PEEP, you lose all your recruitment. The alveoli collapse. If the alveoli collapse, they lack surfactant, so they can't open back up. So you're not oxygenating your patient. You're breathing for your patient, but you're not oxygenating your patient. And it may take minutes or even hours to recruit back all the PEEP that you had at one time. It's just not worth it. So put a PEEP valve on them, keep it on them. If you need to switch out for something, clamp the ET tube to maintain that PEEP in their airway, especially if they have respiratory diseases that require high amounts of PEEP to adequately oxygenate your patient. Lung pathologies. There's many different pathologies that patients can, or diseases that patients can have, lung diseases. When you approach your patient, you need to assess for the patient's work of breathing, retractions, shortness of breath, tachypnea, rapid respiratory rate, shallow respiratory rate, belly breathers. If you're looking for kids, they're all belly breathers, but the severe retractions, you can see the retractions up into their neck and then around their collarbones and stuff. They're really working hard. Upon auscultation with these patients who are having trouble or increased work of breathing, it may reveal rhonchi, rales, wheezes. If there's no wheezes, that means your no air is moving. So those status asthmaticus kids or patients that have been, having an asthma attack for a prolonged amount of time, and they may not be moving any air, so they need bronchodilators, steroids, possibly intubation if they're starting to wear out. Also coarse breath sounds, which like airway obstructions, so you're looking at like fluid in the lungs, stuff like that. Residual values may show decreased SpO2 reading and an increased CO2 reading. Hypoventilation. So either if the patient is breathing too slow or you are breathing too slow for your patient, whether you're using a BVM or a ventilator. When respirations fall below normal, they may not have, they may have enough blood but not enough ventilation. So your VQ mismatch kind of switches. So your circulation's good, you're getting enough blood going in there, it's trying to drop off the CO2 and pick up oxygen, but you're just not breathing fast enough to keep up with it. That's going to create a VQ mismatch, and that perfusion is greater than ventilation. So like I said, you got enough blood, just not enough oxygen. This results in the shunting of blood. So that's going to shunt the blood that is getting oxygenated to your core. So you're going to have cold, cyanotic extremities because it's trying to preserve your vital organs in your brain. Extreme causes of this may be a flail chest. It increases airway resistance and or respiratory rest. All those can cause a VQ mismatch where perfusion is greater than your ventilation. Normal respirations, when ventilations are good and perfusion is bad, so your patient's breathing fine, you're lacking enough blood to get to the lungs to oxygenate the rest of your body. This creates a VQ mismatch in which there's not enough blood passing through the pulmonary capillaries. So like I said, there's enough oxygen there waiting to be dropped off into the bloodstream, just not enough blood there to take advantage of all the oxygen that's kind of just hanging out in the alveoli. This can result from a pulmonary emboli, severe volume depletion, failing right ventricle, or cardiogenic shock. So if you have a blood clot in your lungs, so it's limiting the amount of blood that's able to surround your alveoli. Severe volume depletion, so people who are maybe have like a lower GI bleed or any reason why they are lacking blood volume. So that's why they say fill the tank. So you're trying to stimulate red blood cells to be produced. That's your oxygen carrying capabilities to get to the lungs to be oxygenated, drop off your CO2, oxygenate the rest of your body. A failing right ventricle, basically your right ventricle can't keep up, so it's going to back up blood into your system, into your body. It will back up blood to your right atrium, back into your cardiovascular system. You'll see pitting edema, starting in lower extremities, but then that's when you'll start seeing JVD, jugular vein distension in extreme cases. These all present a physiologic dead space due to gas exchange not occurring in respective areas of the lungs. So certain area of the lungs, so if you got a pneumonia in one of your right lobes or one of your lobes, it's preventing gas exchange to happen right there. So that's going to give you a VQ mismatch where the oxygen is there, just not enough blood to carry the oxygen to the rest of the body. Asthma. Asthma is an inflammatory disorder of the lower airways. Antigens trigger allergic reaction, releasing histamines, prostaglandins, leukotrienes, cytokines, interleukins, and eosinophil factors. Those are all big words. Basically, asthma is, like I said, is an allergic reaction that causes your lower airway to constrict, limiting the amount of oxygen that can get into your lower airway. Lower airways swell and cause increased airway resistance and trap air. So this is going to trap air. So not only is it hard to get air in, it's hard to get air out. You got to be real careful when you ventilate these patients. These are the patients you got to adjust your inspiratory and expiratory time because they take longer to exhale because their airways are tighter. You're going to give a bronchodilator for this. You're going to give steroids. like your solubendarol, and even possibly a mag drip to really try to open up those lower airways and cause smooth muscle relaxation and give your body the ability to breathe, exchange oxygen, and perfuse the body and oxygenate the body. Asthma treatments, here we go. So your albuterol and Atrovent, those are like your A&A treatments. So you can either do them with the pipe or do it in a BVM with the canister underneath it. Like I said, mag drip, those work really well if your service has that and you have protocols for that. If you're going to intubate a patient with asthma, the induction agent you want to use is going to be ketamine if you carry it. For one, it does not knock out the respiratory drive, which is very important for people who are having a hard time breathing. Also, it is a bronchodilator, so it will help, it will complement these other medications that you're given to open the airway. So ketamine is just all around good sedative induction agent if you have to intubate a patient in respiratory distress, especially asthma. Give fluids. You want to give a fluid bolus. This kind of starts breaking up that mucus and it mobilizes secretion. So if you can kind of shake it loose and help start ventilating or help with gas exchange, that's always important. If you ever worked in the hospital setting, especially in pediatrics, if a kid comes in with asthma, the first thing he gets, other than steroids and breathing treatments, is a little fluid bolus to start breaking up those secretions. These patients will benefit from a higher PEEP. This will help open their lower airways, help maintain their airway, help keep their airway open. Because, like I said, it's a constricted airway, so the more positive and expiratory pressure they can have when they're blowing out, because most of the time they're probably auto peeping pretty well when you get there to, like this is COPD, but COPDers also do the pursed lips auto peep to try to help get that air out, keep their alveoli open. It's just your body's natural way of trying to save itself. So if you have to intubate these patients, higher PEEPs are probably required for them. Also, ventilate your patient at the respiratory rate they were at before you put them down. So if they're breathing at 32 times a minute, don't send them at 14. We'll get into that later, but that's a big no-no that a lot of people do, say that 14 or 16 breaths per minute to a patient that's breathing 25 to 35 breaths per minute. Well, your body does a pretty good job of saving itself and trying to get back to homeostasis. So if they're trying to blow off a bunch of CO2 by breathing rapidly, and you cut them down to half, then you may be helping cause respiratory and metabolic acidosis. But like I said, we'll touch on that later when it comes to ventilator settings and how to set your ventilator with these different kinds of lung diseases. COPD, here we go. COPD, these are your blue bloaters. Emphysema also falls underneath the COPD, and those are your pink puffers. Like asthma, it can be slow onset, days, weeks, months, or it can be acute, which is immediate. They immediately have a problem. You'll see a lot of these patients flare up. You'll get a lot higher call volume for these COPDers and emphysema patients when the seasons change. So if you're going from like summer to fall or winter to spring, when things start blooming, allergies pick up. So allergies on top of COPD, you got respiratory distress. 85% chronic bronchitis. Of these COPDers, 85% are chronic bronchitis with increased mucus. So when I was talking about how you get that layer of obstruction between your alveoli and your bloodstream, that in COPDers, that is what it is. So mucus builds up between your alveoli and your bloodstream, causing oxygen exchange to be more of a challenge for your body, basically. Also, they lose, your alveoli lose surfactant on there too, so when your alveoli collapse, they're not going to reopen. They have to have surfactant to keep them basically lubed, to keep opening and closing. When you have COPD and emphysema, you lose that. Emphysema in particular, so they got their dry airways. These people are going to be, both of those chronic bronchitis and emphysema are going to be air trapping because they have a hard time getting air out, so they're going to be barrel chested. Pink in emphysema, they will legitimately be pink. You can tell they'll have a pink tinge to their skin, especially from like the, their diaphragm up, nipple line up. Their alveoli, or their airway, alveoli in particular, lose elasticity and their alveoli are dry. So that in particular, their alveoli collapse. They don't have any surfactant. They will not open back up. These patients require very high PEEP settings on your ventilator. Pulmonary fibrosis. This is the tissue is thick and stiff from scar tissue. Most causes of pulmonary fibrosis are asbestos, silica, sarcoidosis, and tumors. So pulmonary fibrosis is a result of these. That is not the, there's an underlying cause of why your patient has pulmonary fibrosis. And drugs will not help in this situation, so there's nothing you can give them medication-wise to assist and improve their oxygenation and lung compliance. They need high FiO2, so high oxygen percentages on your ventilator or BVM. You need to increase your PIPs. So due to the thick and stiff scar tissue lung, they're not as compliant. So your peak inspiratory pressure needs to be high to force that air into that stiff, thick airway. Very high PEEPs and increased pressure support. We'll get into pressure support later when we're talking about ventilator settings, but that's basically the pressure that stays in the airway when they're exhaling. So high PIPs, high PEEPs, and high FiO2, because they need definitive care. Like I said, there's nothing medication-wise you can give these patients to fix them and make their lungs more compliant. ARDS, acute respiratory distress syndrome. This is also an underlying issue causes this. So I think I had, yeah, so some organisms such as pneumonia from bacteria, viral, fungi, fluenza, or VAP is a root source of this infection. So they're going to have some kind of underlying cause that causes ARDS. This is an infection of the alveoli causing pulmonary edema in the absence of depressed left ventricle function or volume overload. Patients can also develop SIRS, sepsis, and MODS, and also septic shock from ARDS. A lot of times when a patient is septic, they take a chest x-ray, glassy infiltrates, it's ARDS, all that runs together. Lung tissue becomes very leaky and cause alveolar collapse. So your the fluid, so your volume overload, is going to leak into your lungs, causing there to be a hue mismatch, not allowing your oxygenation, not allowing your blood to be oxygenated from your alveoli, and also not allowing your blood to drop off CO2 into your alveoli to be exhaled. So ARDS, not the underlying cause. There's always some organism, or most of the time it's an organism like a bacteria, a virus, or a fungus that causes this. Congestive heart failure. Usually, most of the time, CHF is left ventricle failure causing pulmonary edema out of the alveoli rather. So your left ventricle cannot keep up with the amount of blood that's being pumped to it from the rest of your heart. So lung starts to backs up into your left atrium, to your pulmonary vein, into your lungs, and then eventually pulmonary artery, right side of your heart, and then to your body. So blood shunting, as air is not able to reach the alveoli for gas exchange. So basically, like I said, blood is going to back up into your pulmonary system. It's going to build up pressure. It's going to start leaking into your alveolar space, causing a VQ mismatch, large VQ mismatch. So oxygenation and ventilation is happening, but oxygenation is not. These require high PEEPs and pressure support. So you want to keep the airway open. So that CPAP plus the pressure support is going to increase the pressure in your lower airway. This is going to force the fluid back into the vascular system and out of your respiratory system, making your body more able to ventilate properly how it's supposed to. Also, vasodilators may shift fluid back intravascularly and by reducing preload. So you want to start a nitro drip on these patients. That's going to vasodilate. It's going to change the pressure, the whole osmosis and diffusion from an area of higher concentration to lower concentration. It's going to diffuse across the semipermeable midbrain, go back into your circulatory system, and out of your lungs. So these people require high PEEPs, CPAP pressure support possibly, and vasodilators to draw that fluid back into their vascular system and out of their respiratory system. Pneumos and hemothorax. An open pneumo requires a 3-sided occlusive dressing, so a stab wound, gunshot wound, anything that's open to the atmosphere. This allows air to be forced out, but when you go to take a breath and you have negative pressure, that 3-sided occlusive dressing will trap up against the body and prevent as much air coming in. It's going to allow a little bit, but they need definitive care and they need a surgeon. So do what you can in the field, get them to the proper facility. Closed pneumo does not require treatment until it tensions and produces a hemodynamically unstable patient. So as air continues to be leaked out of the lungs into your pleural space, it's going to start putting pressure on your lungs and your heart. When your lungs are unable to take an adequate breath, your SpO2 is going to drop. You're going to have VQ mismatch, and it's going to start putting pressure on your heart, which will your heart's not able to beat effectively and efficiently. So you're going to have, you're probably going to have, your patient will become hypotensive, and you'll start seeing narrowing pulse pressures, kind of like in a cardiac tamponade. You treat that with a needle decompression or a chest tube. In the field, you're going to do, most likely going to do needle decompression either mid-axillary or mid-clavicular. Hemothorax may require a drain and or surgery. So if you have like a Turkle needle with that little catch, you turn it down and it'll allow that fluid to drain out. You can also draw out of that with a syringe, so if it starts filling up, you can draw and it'll continue to work. Pleural effusion is a buildup of fluid between the lungs and partial pleura and the visceral pleura. This can be very painful. It may require respiratory support, CPAP plus pressure support, which I'll get into that later when we talk about ventilator settings. This is basically your bi-level setting or what people would call BiPAP. but they may need a thoracentesis or a chest tube, so kind of like pericardial centesis, but except for it's in your pleural space. So they're going to draw the air or draw the fluid out of that pleural space and allow your lung and chest expansion to happen as it's supposed to. Absorptive atelectasis is a collapse of the alveoli due to high concentrations of oxygen and washing out of nitrogen, which accounts for 78% of the volume in each alveoli. Oxygen toxicity. So years ago, everybody got 15 liters non-rebreather. Well, studies show that that's absolutely doing no good for your patient if they don't need it. So if they're 94 to 99 or 94 to 100, they do not get that because you can cause oxygen toxicity, which causes central nervous system problems, seizures, cell damage, as free radicals are created inside the lung. Also, absorptive atelectasis may lead, and this can lead to ARDS. So what you need to do, so if you have someone with absorptive atelectasis, you need to continually add PEEP until the process is reversed. So keep that pressure up in their lungs, in their airway. All right, so ventilator theory, as I was saying before, your body naturally breathes through negative pressure. When we throw them on a ventilator, we switch that up completely. We put them on positive pressure. History of ventilators. Basically, this is the only negative pressure ventilator that's ever been invented. It's the iron lung. I got a picture of it. It's a tube, basically, that you have to live in. I don't know which would be worse, to die of some lung disease or having to live in a tube. But that was built in 1928. Throughout the years, as we gotten closer and closer to current times, ventilators have gotten better. The next one was gas operated. These are electronic from the 1970s on, but they were big. In 1999, they finally made the first laptop size ventilator that you can carry on like a mobile ALS unit. There's a picture of the iron lung. So you basically have to live in that thing. When you come out of it, you slowly start dying. I think there's actually not too long ago someone who was still like the last living person that was living in an iron lung, but it's not much of a life to me. Okay, as you can see, this is a ventilator in the 70s. How big it is, kind of resembles what hospital ventilators, some OR ventilators look like at least. Still not that big, but bigger. And then this is a picture of kind of what we're going to now, these small compact units. Pros and cons. Ventilator pros, for patients who's exhausted and has no respiratory drive, it requires no effort from the patient. Or you can actually set it up where it just assists the patient. So if you don't want to knock your patient out and completely kill the respiratory drive and fear that they may not get it back, severe COPDers or emphysema who are really, really tired, if you put them on a tube and on a ventilator, they may never come off. It increases oxygenation, improves ventilation, and it protects the airway. Cons, if you're not careful with your vent settings, you can cause barotrauma by breath stacking or too high tidal volumes or too high pressures. Oxygen toxicity, if you're not trying to wean them off on your FiO2 settings. Auto PEEP, which comes from breath stacking basically. Diaphragm atrophy, that's what I was talking about, how if the body's lazy, if it doesn't have to work, it's not going to, and it will quit. Decreased cardiac output, so if you're overinflating their lungs, it's going to put pressure on your heart. Being that you just switched their system from negative pressure to positive pressure, you're going to put pressure on their heart, decreasing cardiac output. Triggers, so you can adjust your triggers on your ventilator. Triggers are what you set to determine what it takes for the patient to initiate the breath on a ventilator. So too low a pressure causes the patient to work harder to overcome the trigger. So if the patient has to pull a certain amount of millimeters of mercury, or a certain amount of mils, I guess I should say mils, of oxygen before that ventilator kicks on, if their trigger is low, it's going to require more effort for the patient to trigger a breath. Too high pressure, it becomes super sensitive, which may cause barotrauma or ARDS. So if it's real sensitive, just the vibration of your ambulance or your aircraft, if your patient's trying to take little short breaths, you may lower your trigger and your vent won't pick up those little breaths and just breathe at the rate that you have set. If it's triggering too often, make sure patient is sedated. So go through, make sure your respiratory rate's adequate. If everything's good, sedate your patient. Or switch to SIMV for patient comfort, and I'll get to that, the difference between SIMV and assist control. But once you, after you troubleshoot all those, you may just need to lower your trigger to reduce false inhalations. Smaller circuits are more sensitive, and if your patient being obese, can also cause false breaths and making your vent trigger. Respiratory rate of what the patient was breathing at before you put them under. Like I said, if your patient's compensating and they're breathing 30 times a minute, don't set them at 16. Their body's doing that for a reason. They're trying to blow off CO2. The set rate is what the ventilator mandates. Your patient can overbreathe the vent, and I'll get into the different settings and what your vent will do when your patient takes a spontaneous breath. And respiratory rates can be tailored to the patient's breathing pattern. So if the patient actually wants to breathe at 18, you can set it at 18, and you got green lights the whole way. And also, your respiratory rate affects your end-tidal CO2. So if they need to blow off some CO2, or if they've blown off and they're a little alkalytic, then you can slow the respiratory rate down and get them back to homeostasis. Tidal volumes, the amount of air we introduce into the lung. So this directly affects your end-tidal CO2. Our protocol is 4 to 10 mils per kilo of ideal body weight. So if your patient is severely overweight, but only if he's 5'6" and 300 pounds, you do not want to set your tidal volume for a 300-pound patient. You want to find their ideal body weight, set it to that. I'm pretty sure I can speak for most people with the company and other clinicians out there that most people try to stay between 4 and 8 mils per kilo. 10 is pretty aggressive. But what you're looking for is adequate chest rise, adequate oxygenation, and a good end-tidal CO2 between that 35 and 45. To calculate minute volume, it's your tidal volume times respiratory rate, and that's how much volume they're getting in a minute. PEEP is the amount of pressure remaining at the end of exhalation to keep the alveoli from collapsing. This assists in recruiting additional alveoli. Atelectasis from inhibited type 2 cells from the disease process and improves oxygenation. So with that being said, I'm going to show you a quick video on the importance of PEEP. This is a set of pig lungs we had at work. We hooked them up to the ventilator. So PEEP's been going, we've had these lungs on PEEP, and that PEEP does not allow your lungs to fully deflate. It keeps pressure in your airway and keeps those lungs open and ready to accept another breath and assist in oxygenation. So you see they expand, but they don't collapse completely. They stay inflated. You got to watch that because you don't want to overinflate. You don't want to cause auto PEEP or breath stacking, because then you'll have issues with putting more pressure on your heart, decreased cardiac output, and all that stuff. So that is the importance of PEEP, keeping the airway open. So COPDers, high PEEP; emphysema, high PEEP; asthma, high PEEP. Physiologic PEEP, as we talked before, is 4 to 5 millimeters of mercury on everybody. So everybody gets a PEEP valve, or a PEEP of 5 on the ventilator minimum. Auto PEEP can result in barotrauma and decreased venous return on the right atrium. So if you basically breath stacking, So it's just read it as we're introducing increased atmospheric pressure via positive pressure ventilation. So you're switching from negative pressure to positive pressure. A phenomenon can occur in which air cannot exhale fast enough. Remaining air causes the PEEP to continually increase inside the lungs. So you may have your PEEP set at 10, but because you're not allowing them to fully exhale, PEEP is going to continually increase, causes barotrauma, could be a cause of atelectasis, puts more pressure on your heart, decreased cardiac output. FiO2, increase FiO2 for improved oxygenation. Your FiO2 is between 0.21 and 1, so it's 21%, which is atmospheric air, and 100% oxygen. You want to keep your ABGs, you want to keep the PaO2 between 80 and 100. If it falls below 80 and down to 60, it may indicate sepsis or ARDS. So when you're got a patient on the ventilator and they're doing good, they're maintaining 99, 98, 100 SpO2, you want to start weaning them off the FiO2 because you don't want to cause oxygen toxicity, because anything over 40% could lead to oxygen toxicity. So start weaning your patient off and try to get them to the lowest FiO2 percentage you can to facilitate 94 to 99% SpO2, but you definitely want to use as little oxygen as required to keep those within normal ranges. Oxygen toxicity can affect the central nervous system with vision problems, motor skills, and cognitive abilities. It may cause seizures. Absorptive atelectasis is what we talked about earlier. Basically, oxygen steals electrons and generates free radicals inside the lungs, causing tissue damage and can lead to ARDS. So, again, we're going away from everybody gets 15 liters non-rebreather. You only get oxygen if you need it, and when you do need it, you're getting as little as you need to maintain desired SpO2 readings. I to E ratio, that's inspiratory and expiratory ratio. This setting manipulates your inspiratory and expiratory times. You may need to prolong a prolonged exhalation for COPDers with your chronic bronchitis or emphysema, as well as asthmatic patients. Their airways are constricted, their lungs are less compliant. It's going to take longer to get that oxygen or that breath out. So some patients may benefit from longer I times, inspiratory times. So also with that being said, if it's hard to get out, most of the time it's hard to get in. So whereas others may benefit from just slowly longer expiratory times. Typically, you're on a patient who does not require those, you're going to set your IDE up 1 to 2. So 1 second inhaled, 2 seconds exhaled. Pressure support. Pressure support is the amount of pressure to support breathing effort to overcome increased airway resistance. This can only be done in SIMD mode, and we'll go over SIMD mode in just a minute, but when I place a patient on SIMD mode, pressure, not volume, SIMD pressure, I'll put them on a 10 of pressure support every time. This eases the workload on patients who are able to take spontaneous breaths. As inspiratory times decrease, you may need to increase your pressure support to overcome airway resistance. Smaller ET tubes will require pressure support. So the more resistance in your airway you have will require higher pressure supports. Peak inspiratory pressure, PIPs. You want to keep your PIPs between 15 and 40. Really, you want to stay under 30, but if you have to go up higher than that, you do not ever want to go higher than 40. That's the highest level of pressure applied to the lungs during inhalation. So like I said, you want to attempt to stay under 30. Just it's safer for your patient. You're not going to cause any barotrauma. You're not going to eventually cause atelectasis You can go up to 40 as long as your P plats are under 30 centimeters of water. So your pips are, on our vents, are a setting that's in your pressure control reading in volume control. So you either set patients up on volume or pressure, and we'll get to that in just a minute. Plateau pressures. Plateau pressures measure or give a direct view of alveolar compliance. The mean airway pressure after inhalation. So inhalation, our ventilators, you have to hit a button. The nicer ventilators, I know like the Hamiltons and the and other ventilators give you a constant P-plat reading. P-plats, if they're over 30, can significantly cause more damage than PIPs as the duration is longer. So there's more pressure on the lower airways for longer than what your PIP, your peak inspiratory pressure is. So never let your P-plats or your plateau pressures go over 30 centimeters of water. So here we go, modes of ventilation. So you got assist control, pressure or volume, volume control, pressure or volume. So that's your SIMV. CPAP, either positive pressure ventilation or non-invasive positive pressure ventilation. CPAP puts pressure support with positive pressure ventilation or non-invasive. So that your CPAP plus pressure support are going to be like your bi-level or your BiPAP setting, like what's in the hospital. Volume and pressure. The volume control. In volume control, the tidal volume is set on the vent and every breath receives that prescribed amount. It may be beneficial for patients without lung injuries and need to blow off additional CO2. So if you set the tidal volume at 500, every breath they're getting 500. Pressure mode is my favorite personally. It is utilized in patients with lung injuries as to protect the lungs or allow tidal volumes to exceed normal prescribed volumes in patients with open chest wounds. So basically pressure mode is going to deliver a breath until a certain pressure is reached. So volume is going to go give you 500 mils or whatever the setting is in 1 second. Pressure is going to increase pressure in the airway until a certain pressure is reached, and that's going to give you a tidal volume. A lot of people don't like pressure mode because you can't set 500 and see 500 every time. You're going to see, if you're trying to get 500 mils of your tidal volume, you're going to see 480, 515. You're not going to be constant, but in my experience with ventilators, the pressure mode is a more natural breath. And with the open chest wounds, if it's on volume control, it's going to give 500 mils. It's going to go in their lungs and out the hole. Where in pressure mode, it's going to feel until it hits that pressure, and then it's going to stop feeling. So you're going to be able to ventilate your patient in pressure mode if they have an open chest wound. Rather, if it's in volume control, your patient's not going to be ventilated properly, at least. Assist control gives a breath at a set rate. It can be in volume or pressure. The patient is allowed to initiate a breath. The only problem with assist control is if your patient initiates a breath, if whatever tidal volume you have set or whatever pressure, it's going to get that. So if you have a 500 tidal volume in assist control and they initiate a breath, they're getting 500, no matter how shallow or big their breath is. This is good for patients who are fatigued or after surgery need to rest from respiratory workload, or if your patient is chemically paralyzed. So if they had like a VEC or a rock that's going to last 30, 45 minutes to an hour, and they're not going to have their own respiratory drive, throw them on AC or assist control. It's going to breathe, set volume, set pressure, whatever tidal or whatever respiratory rate you have. With that being said, if they are initiating breaths, you do run a risk of hyperventilating because when they do initiate a breath, they're getting 500 mils or whatever the tidal volume is set. But assist control is good for acidosis, and it helps blow off some of that CO2. synchronized intermittent mandatory ventilation, SIMV. So when I really like putting patients on SIMV pressure. It still delivers a breath, so if you got it at 10 breaths per minute, it's gonna give them a breath every 6 seconds. But if a patient initiates a breath, it's only going to give what the patient wants. So if you got it set at 10 breaths a minute and your patient's breathing at 12, but breath 11 and 12 only are 250 mils, that's all the patient wants to take or is taking, that's all it's going to give them. It's not going to force that additional volume into their lungs. I always put them on a pressure support of 10 minimum. To me, it's more comfortable for the patient and is used like in ICUs or like cardiac step downs for like when patients come out of surgery and they're trying to wean them off the ventilator. The risk with this is hypoventilating your patient because you want to make sure that the respiratory rate's fast enough, and if they're initiating breaths, that they're getting enough regular breaths to properly oxygenate their body. This is good for alkalosis. So AC, acidosis, SIMV, alkalosis. CPAP, non-invasive. EPAP, which is PEEP, expiratory positive airway pressure. So you set your IPAPs and your EPAPs. This is only good for a small group of patients who require oxygenation but do not have an increased work of breathing. Positive pressure ventilation mode is used for weaning the patients off the ET tube or vent. So it's just another setting to assist in weaning patients off the ventilator. Probably not really going to deal with this in pre-hospital settings, but in your inter-facility transfers, maybe something good to learn up on and be familiar with, so you can keep that patient on the same setting and not changing things up while your patient's trying to get off the ventilator. With CPAP though, your patient cannot be obtunded. They must be able to follow commands and protect their own airway. So that's a big thing. If they are obtunded and not able to protect their own airway, they're not allowed to be on CPAP. CPAP plus pressure support, non-invasive. This is your bi-level. This is your BiPAP of your ventilator. So you got a expiratory and an inspiratory, which is, so your inspiratory is pressure support, your expiratory is PEEP. So you set those. This is for patients who have increased work of breathing. So where like if you were working, going from ground to air, I put patients on CPAP. Well, now with longer transports, you got to think of oxygen conservation. So you want to set your patients up that's going to help them, but also have enough oxygen to get there. So this bi-level setting still maintains that expiratory pressure, that increased PEEP that like COPDers and emphysema patients need, without depleting your oxygen. So you're just going to adjust your rise times. Lower the rise time, the faster the breath, the higher the rise time, the slower the breath. Again, your patient must be able to follow commands and protect their own airway. So these are references I have for this presentation, where I got a lot of my pictures and information from. If you have any questions, ask me now. I want to pass out the quiz and the I'm trying to think of where you grade me. So anyway, thank you for listening.